So today we will see pneumothorax in nutshell. So pneumothorax is nothing but air in pleural space. It is an emergency. It should be treated immediately. It could be a primary or it could be a secondary. Primary means without any pathology. Secondary is because of some underlying pathology like COPD. And pneumothorax could be traumatic also uh, because of CVP, thoracocentesis, barotrauma. Primary pneumothorax need treatment and observation or thoracostomy. Secondly, pneumothorax requires immediate thoracostomy or pleurodesis. So, what is tension pneumothorax? When there is it is a series consequence of pneumothorax. One-way valve mechanism is there. Air enters in pleural space during inspiration but doesn't come out during expiration. So air is built up inside the pleural space and it increases the pressure inside. Because of there is collapse of lung vasculature is also compressed and it present as dyspnea, hypoxemia, hemodynamic compromise. Clinically, if we see there are absence breath sounds, shifting of trachea to opposite sides, increased JVP, engorged neck veins are there. So, if you suspect pneumothorax in mechanically stable patient, initially the patient is stable or improving, and suddenly it becomes decompensated or become unstable during or after some procedure. Okay, so how will you manage the pneumothorax? So this is the management flow chart for pneumothorax. So initially, if we suspect pneumothorax and patient is unstable or tension pneumothorax, we are suspecting. If it is yes, means patient is unstable. Yes, so we will give 100% oxygen immediately and immediately do needle thoracostomy, or after that tube thoracostomy. If patient is not unstable or patient is stable, there are no chances of pneumothorax. We will do an X-ray after for confirmation the diagnosis. If X-ray is showing the patient is stable and X-ray showing pneumothorax only 15% of hemithorax. Then if pneumothorax is only 15% of pneumothorax and patient is stable, we will observe patient. If no, patient is unstable, we will do tube thoracotomy. So this is the flow chart of management of pneumothorax. Okay, so you can read. So what are the indications for removal of chest tube when we put it? So when pneumothorax is resolved, no air leak in chest tube or lung remains expanded more than 24 hours. If there are concerns about the pneumothorax, clamp the tube for 48 hours and take an X-ray. If lungs are expanded, remove it. So about some few words about the tube size, chest tube size. So usually we use small size, less than 14 French. It is easy to put by Seldinger technique. It causes less pain, decreases complication, and less complications are there. It is recommended in pleural drainage or pneumothorax. A large tube, more than 22 French, is used in mostly hemothorax or barotrauma induced pneumothorax. Okay, thank you.